Good evening, everyone, and welcome once again to another episode of Renal Rounds. We are going to talk this evening about the challenges of water purification for dialysis. So, just to set the stage, we are going to talk about some high-level issues with water purification that we should consider while developing a water treatment system for our dialysis units. Also consider what are the quality parameters we should keep in mind and what are the other issues that we will be confronted with going forward. So just so that everyone knows, we know that an average person drinks approximately 14 liters of water in a week, which is about 2 liters a day. Of course, it can go up or down, especially in summer months, the water consumption does go up. But an average person is able to excrete toxic substances in urine, and the contaminants, if there are any in water, they are selectively absorbed in gastrointestinal tract, and they are only indirectly exposed to blood rather than being directly in contact with blood. On the other hand, a hemodialysis patient is exposed to approximately 1400 liters per week, and this will increase to about 800 liters for a person who is on nocturnal hemodialysis. This person's kidneys are, of course, unable to excrete toxic substances, so they accumulate in the bloodstream, and contaminants, if any, in water that a person on hemodialysis is exposed to directly come in contact with blood, with the only thing separating the two is a semi-permeable membrane across which many of the contaminants present in the blood can actually cross. And just to give you a visual idea of what is the difference of weekly water exposure between a normal healthy person whose water intake is shown here, it can be 5 bottles of 2 liters, which is about 10 liters, or it can be up to 7 bottles, which is 14 liters. On the other hand, this is the water exposure of a person on hemodialysis, which is about 360 liters here, shown here, but it can go up to about 400 liters as well. So it does become clear that because of exposure to such large quantities of water and because of the kind of exposure in which the contaminants, if they are present, will come directly in contact with blood, we must really be very careful with these contaminants. So what kind of contaminants can we be dealing with? They could be either chemical contaminants or they could be microbial contaminants, okay? So 2 types of contaminants. So let's look at, first of all, the chemical contaminants and their toxic effects. So I'm getting a message from someone that the presentation is not running, but I think it should be running. If anyone else is also not able to see the presentation, do let me know by sending a message. Okay, so we'll just go back to the PowerPoint, and let's look at the chemical contaminants and their toxic effects. So the most common chemical contaminant that we all have been familiar with historically is aluminum, and it has been very well linked to the development of dialysis encephalopathy and renal bone disease. However, there is a list of contaminants which are shown here, and the number of possible effects which can develop in these individuals is shown in the column on the right. So common chemicals like calcium, magnesium can lead to development of hard water syndrome, hypertension or hypotension. Chloramine can result in hemolysis and thereby anemia, and it can also cause methemoglobinemia. Copper has a number of symptoms, as has fluoride. Of course, you perhaps don't think of sodium as a contaminant, but sodium can be a contaminant of water during dialysis if the concentration is inappropriately high or low, and it can cause hypertension, pulmonary edema, confusion, headache, etc. Of course, nitrates, high iron, sulfate, zinc, and aromatic hydrocarbons are all other types of chemical contaminants. Let's go to the microbial contaminants now, and the types of microbial contaminants you can have are either intact microbes, microbial fragments, and endotoxins, which are produced by microbes, right? So the microbes you usually identify by culturing them and doing a colony count. So the attack rate of any microbial pyrogenic reaction, if the colony count is less than 100 per milliliter, is about 4%. However, if it goes up to 10,000 or greater per ml, the attack rate increases to as much as 1/4 or 24% of all patients. The recommended colony count is roughly between 100 to 1,000. So anywhere in 3 figures or lower than 3 figures is what is recommended. What are the common bacteria which are found in dialysis? They're all listed here. So what you will notice is that most of these bacteria are not the ones that you usually encounter in your clinical practice, and the ones that patients come with during a usual bacterial infection like urinary tract infection or pulmonary infection. Okay, so what is the characteristic of these bacteria? These bacteria typically exploit the nutrient poor niche environment, because dialysate is very, very poor in nutrients that normal bacteria consume. So only those bacteria which do not require a lot of these traditional nutrients can thrive in a dialysate, which are the ones that are shown on the left. The other characteristic is that these bacteria grow very, very slowly. And the third is that this is one of the most important characteristics, and something that we should think about is that these bacteria survive in biofilms for a long, long time. Okay. However, when we talk of microbial contaminants, we usually talk of bacteria, but we don't talk about viruses and fungi. We don't know much about it, but it is quite possible that viruses and fungi also contaminate dialysate that we use. So this is the diagram of a typical water treatment system. Typical doesn't mean the best water treatment system, and typical also doesn't mean every possible water treatment system. So you start with typically municipal water, but in many instances in India specifically, we may not start by municipal water. You may have water brought in by tankers. So we should just be mindful of that, and we'll come back to that in a moment. So the municipal water goes through a pre-filter, then it typically goes through a carbon filter, water softener, and there is a post-filter, after which it goes through a reverse osmosis unit, and then you have your dialysis machine. And there could be other, then you have a pathway in which it might go to a water storage tank, and then from there it goes to individual hemodialysis machines. And it can of course recirculate, and there is another pathway, which is the pathway B shown here, in which this water can be recirculated through the reverse osmosis unit as well. So we have a current standard for water quality for dialysis, and these current standards are not fixed, but they reflect decades of development, experience, and constant refinement that have taken place in water treatment standards. And these achieving these standards requires an integrated sequence of purification devices and disinfection measures. So you don't have one single magic bullet which can produce pure water, but it must be an integrated and sequentially performed purification. What happens when we fail to meet water quality standards? Said very simply, it leads to increase in mortality and morbidity of patients on dialysis. So what are the safe levels? So the first thing to say is that the safe levels that we talk about are actually arbitrarily laid down guidelines by ISO or ANSI, AAMI, which were updated in 2009 to 2011. These are typically 10-fold reduction from levels which are recommended for drinking water. So that is the arbitrariness that has been brought in. And these are the recommendations usually for dialysate in dialysis water in North America. However, the water norms are much stricter in Europe and Japan, and please do remember that the outcome of patients on dialysis is also better in Europe and Japan. Of course, the best outcomes are seen in Japan, which have the strictest water quality standards. The maximum allowable levels for TVC and endotoxins in standard and ultrapure dialysate fluid and dialysate water are shown in this table, which appeared in the paper in Nature Reviews Nephrology in 2012. I'm sure all of you know about the difference between standard and ultrapure dialysate water, so we won't go into all of those. So, but I just wanted to draw your attention to these two parameters. One is maximum allowable level. So, and the second is action level. So, even if you of course need to be below a maximum allowable level, but typically the action level is 50% of the maximum recommended level. So even if, so for example, if the endotoxin allowable level is less than 0.25 endotoxin unit per ml, if your water endotoxin level consistently exceeds 0.125, which is 50% of 0.25, you should look for causes and you should start actually doing something about it. So this is divided into 3 columns: dialysate water, standard dialysis fluid, and ultrapure dialysis fluid. In ultrapure dialysis fluid, you don't have these 2 separate levels because the levels are so low that the maximum allowable level also acts as the action level also. Now, even though you know all about ultrapure dialysate, but just to recap, it reduces chronic inflammation. It also reduces erythropoietin resistance. It is said that it preserves residual renal function. It also might reduce beta-2 microglobulin amyloidosis and reduces the development of advanced glycosylation end products. Having said all of this, even though theoretical and experimental data suggests that all these beneficial effects can be seen with the use of ultrapure dialysate, on clinical grounds, there is really very little evidence right now which can support its use unless you are practicing hemodiafiltration. So for regular hemodialysis, evidence that ultrapure dialysate is able to improve outcomes in patients is missing right now. So what are the properties of a well-designed water treatment system? So here are a few high-level points. It should have a smallest possible pipe area. It should minimize complex branching and dead ends, because dead ends and complex branching leads to alteration in flow and stagnant spaces. So stagnant spaces should be eliminated, such as collection tanks between RO unit and patients. So even though we oftentimes need it, but if possible, you should eliminate this. You should also avoid irregular surfaces as much as possible, like joints, etc., because they also act as traps for microbes. You should use materials which are compatible with disinfection system, for example, the chemical disinfection or heat disinfection that you should use, and you should keep the flow on. These are the essential properties of a well-designed water treatment system. Now, suppose you are going to set up a water treatment system and you set up a dialysis unit and you need to actually plan a water treatment system. So before doing that, you must consider the following things, which is the first of all is source water. And here we come to the kind of water that will be used, whether it is a regularly available municipal water or water that comes from tankers, which may have very uneven quality. The reason we say this is that predictable quality allows you to design a predictable water treatment system. However, if the water quality is unpredictable, then your design will always be flawed. So the source water can have naturally occurring substances. It will have drinking water additives, which have been often added for health reasons like chlorine and so on. And please do note that there will be seasonal fluctuations in source water, especially in India, and especially in situations where you have floods and other natural disasters. You should also consider the kind of dialyzer that you are going to use. For example, what is the flux of dialysis that you will use, and whether or not you are going to reuse dialyzers. So what should the standards and guidelines be? So you can look at it in two ways. Are we thinking of mandatory regulation versus any aspirational goal? So you may really design a water treatment system which will meet with the mandatory regulation that any regulatory body might have laid down. In India, we don't have any regulatory body, but I'm sure it will come soon. On the other hand, you may wish to design really a very high quality dialysis unit, and therefore your goal might be more aspirational or even futuristic. So we have seen the maximum allowable limits for various potential contaminants in water, but we should not try to overcomplicate this when we are developing standards and guidelines by even adding trace metals to these regulations, because it is impossible to police that, and you will simply be setting yourself up to fail and for people to violate these standards. Differences, now here is something which is very important, which people don't realize, that we must resolve differences in bacterial culturing methods. And the type of culturing methods which you need to use in looking for a bacterial growth is use very specific media which are nutrient poor media. And you will need to allow the growth to occur for long periods of time, right? Normally you allow, when you send a normal blood culture or routine culture, you are looking for a growth within 48 hours or 72 hours. Here, you will need to wait for even 10 days. You should also consider whether or not to add other microorganisms in your standards and guidelines, like viruses or fungi. And you should, when we develop standards and guidelines, we should also provide guidance on implementation, which is done by European Renal Association best practice guidelines on water treatment. So I will encourage you to go and look for it. Now, it's extremely important to make sure that as a conscientious nephrologist, I'm sure you're not going to be present in the dialysis unit all the time. You are going to leave it on your technicians and on your nurses to run the unit. You will need to make sure that they are complying with what you want them to do, and that your guidelines are being implemented appropriately. And so therefore you should develop facility level quality management based on performance validation. This will start from initial installation and performance, and there should be routine monitoring and periodic revalidation of your water treatment, not only planned but processes. So, and the components of this quality management system should be related to both system design and to system management. Okay. So let's come to system design. So what is system design? System design should cater to center-specific modifications. So here it is important to emphasize the word center-specific. So any generic water treatment system should undergo center-specific modifications to handle differences in source water, which we spoke about a minute ago, that municipal water in different places may not be the same, and sometimes you have to get water from other sources. And so typically the differences that we are expecting to see are in the presence of monochloramine, where you might need sodium bisulfite, orthophosphates, organic material, and silica, which are different in different regions. And so you must measure this in the beginning and then make modification in the system design. The other important thing is prevention of biofilm, and please note that the word prevention is shown in bold here, because prevention is the important thing, because once biofilm forms, it is not going to be eliminated, trust me. Biofilms account for 99% of bacterial burden in a dialysis unit. Therefore, we must ensure an intact hygiene change, minimize entry of microorganisms from environment, and include a bacteria or endotoxin retentive filter in the system. And we must allow regular and effective disinfection. So that was for system design. Now in maintenance, you must develop a predetermined maintenance program which should be executed as planned, very, very faithfully. You must monitor program adequacy, and you must make certain assumptions. For example, you must assume that a biofilm will form. Even though we want to prevent it, we should always work with the assumption that it will form. So that should be the level of system maintenance. Now, how do you do performance monitoring? So the things that you look for are chemical contaminants, which can be seen in the form of total fluorine concentration, percent rejection, and product water conductivity. We should also look for microbial toxins and, as mentioned before, colony counts and toxin levels. But before we do that, before we even go to set up a dialysis unit, we must take organizational considerations into account. So we must have sufficient number of trained personnel. The quality management system for water treatment should be fully integrated into facility quality assurance program. We should be able to see trends on water quality. So just a one-time snapshot is not enough, but you should always draw a trend line to see in which direction your water treatment system quality indicators are going. If they are rock steady in acceptable levels, then you're fine. But if they're going up, then you should be worried even before you hit the panic level. We should, and if once we have seen the trends, we should try to identify potential weaknesses and initiate action to prevent system failure and minimize patient injury. Something which I have said in other contexts, but is worth repeating here in this system also, is that we must use checklists. And if we find something going wrong, we must do a root cause analysis. And there is a method called failure model effect analysis, which is used by economists, which is something which you don't need to do, but that is the kind of thing which has been advocated. Now, home hemodialysis is not practiced really in India, but maybe a few of you are doing it, so I thought we should mention it here. And the important things to remember here is about water pressure. So in a dialysis unit, you can ensure good water supply, but at home, water pressure, as we know, is very, very variable. So we must make sure that the water pressure should meet minimum standard of treatment systems. The quality of feed water again becomes important, and here you must pay attention to the carbon filter. That it must be in use, and the size of carbon filter should be adequate to take care of the chloramine that it will need to remove. Organic contaminants will necessitate use of anion exchange resin to protect the reverse osmosis membrane. So home, because in a dialysis unit, you are not worried so much about organic contaminants, but it can happen in home because your water pipes are often laden with algae, and here the kind of water that you're getting is more likely to have organic contaminants. Now here is a new concept of sustainability. We are in a system where we are always talking of doing our bit to protect our environments. So please do note that hemodialysis is an inherently wasteful process because 70% of all water used is rejected. In particular, single pass machines which we use now are water guzzlers. So what are the potential solutions? The potential solutions are, first of all, better use of reject water, which is shown in this paper by John Eger, which appeared in Kidney International a couple of years ago, which takes, and the design of the system is that a pump takes the reject water from the RO unit and pumps it up into a water storage tank and that water can be used to either water the garden or to supply water to central sterilizing department, supply water to various, to even dialysis unit or to wards for regular use, etc. Or we can minimize the use of water by use of sorbent systems. Fresenius has this annex stage system, or in home settings you can use multiple pass hemodialysis, reverse osmosis. Why is this important? Is because we are living in an era where the world is suffering from water stress. So what is water stress? Water stress is measured by ratios of withdrawal, which means how much water we consume, to supply. So less than 10% withdrawal to supply ratio means low stress, and greater than 80% means extremely high stress. So the more red or orange the color, the higher the stress. And the more yellow or lemon yellow the color, the lower the stress. And here you can see that India is just one notch below the most extreme category. So it is in the high stress, it's a high stress country. And this is, and how it has changed over time is also something which is worth looking at. So this is water withdrawal as a percentage of total available water, which is the same as water stress. And here blue is good. So light blue is light blue is worse than dark blue, but yellow and orange are bad. And India was in yellow color, so it was not the worst, but it was pretty bad in 1995. But see where we are going to be in the year 2025. In the year 2025, there will be a lot of orange in the world, which means the water withdrawal will increase. And one of the more important reasons for increasing water withdrawal will be the projected growth in number of patients on dialysis, which you can see from a paper that we did a few years ago, which shows that the number of people on dialysis will double between 2010 and 2030. And you can see that most of this growth is going to occur in Asia. And this is what shows the water consumption per cubic billion meters. So we must do health economic analysis to see what makes sense in this era of a time where we should look at sustainability, and we should think whether or not hemodialysis is perhaps not the most sustainable way to manage patients on dialysis, and that we should be considering alternative methods of renal replacement therapy more seriously, such as peritoneal dialysis. Peritoneal dialysis, in contrast to hemodialysis, consumes about much less than hemodialysis. However, we must remember that production of peritoneal dialysis bags also leads to consumption of water, and that waste disposal of hemodialysis is also stressful on the environment. So nothing is a silver bullet, but we must do these sorts of analysis. So here is the last slide, which is the slide of conclusions, which tells you that substances in drinking water can injure dialysis patients if not removed. Standards for maximum allowable limits are present, and that improving dialysate quality does improve patient outcomes. We need facility-specific quality management systems. So there are no generic quality management systems for water treatment. System performance validation, routine monitoring, and periodic revalidation is essential. And we need radical change to cut down the wastefulness during dialysis. So what I did over the last 30 minutes or so is to talk to you about a few high-level concepts that drive setting up and maintaining and monitoring a water treatment plant during hemodialysis. And what are the future issues that we will need to confront? And if we need to be leaders and role models for people setting up dialysis units, then we must look at these parameters. Now, I'm sure you have a number of very specific questions, like what to do in this one given situation, or where to send your water for analysis, and those are